Perfect. So thank you, Dr. Nikhil, for yet another interesting, enlightening evening today. A very special topic, which probably after 15 years of practice, you continue to forget and not keeping abreast with what is happening latest in the field of anticoagulation, with so many newer anticoagulations have come in, so many interactions, warfarin slowly getting away from the current scenario. It's great to have Dr. Alok Khurana, who does not need much of an introduction, but still Nikhil will be introducing him. He is a world famous guy in the field of thrombosis and anticoagulation. It's a pleasure to have him and listen his thoughts and his profound knowledge about this topic. And probably tomorrow morning when we wake up and have a consultations on board, we'll be able to do much more justification, and whatever we have been doing, we'll have more conviction into that. A great event. I think that's a great thing to have all of us on this. This has been will be joined by 300 to 350 plus people across Southeast Asia, Middle East, and Africa. So it gives a great platform for Fortis for developing the knowledge base science in the country. And one disease, one doctor, where Dr. Nikhil is spearheading multiple myeloma space, gives you us an immense deep insight into the disease biology, which till now, Dr. Khurana, I can say we are different. More and more, Dr. Srinidhi Nathani has been unraveling myeloid malignancies and similarly lymphoma and myeloma space, the NGS, 3-day NGS, which is the world's fastest in present in the current scenarios, has given us a deep insight of how we interact and how our disease biology is different from the Western people. So with this, I would hand over to Dr. Nikhil. This has been going and been innovation in hematology series has been going on for almost 15 months. Kudos to you, Dr. Nikhil. We look forward for many more series to continue in the future and getting enlightened by the great speakers which you have lined up for us. Thank you. Over to Dr. Nikhil.
Thank you, Dr. Bhargav, for that kind introduction. I welcome one and all to this month's Innovations in Hematology webinar series. When we started this series 15 months back, we all wanted to discuss pertinent clinical questions and challenging case scenarios which we face in our day-to-day clinical practice with experts in the field. Today, we'll discuss few scenarios in therapeutic anticoagulation, especially cancer-associated venous thromboembolism. And for this talk, we are glad to have Professor Alok Khurana, who's a professor of medicine, director of gastrointestinal malignancies, Cleveland Clinic. Dr. Khurana needs no introduction to this audience. He is a pioneer in developing risk assessment models and has done excellent work in the field of therapeutic anticoagulation. His clinical and translational research program focuses on new therapeutics and outcome predictions in GI malignancies and cancer-associated thrombosis. After completing his medical training from Maharaja University Medical College, Baroda, Gujarat, he did his postdoctoral training, including a residency in internal medicine at the University Buffalo in New York and a fellowship in hemato-oncology from the University of Rochester, New York. We are all familiar with Khurana score, which we routinely use for predicting the risk of thrombosis in malignancy patients and deciding which set of patients need prophylactic anticoagulation. He is closely associated with numerous committees. He is a chair of ASCO Clinical Practice Guidelines, also serves on ASCO Scientific Program Committee and multiple other guideline panels and oncology committees. He is a past chair of International Society on Thrombosis and Hemostasis, subcommittee on hemostasis and malignancy. He has numerous publications in international journals of repute and has done pioneering work in the field of anticoagulation, especially cancer-associated venous thromboembolism, in elucidating the risk factors and preventive mechanisms for the same. Before I hand over the session to Dr. Khurana, I would like to introduce our speaker for next month's webinar. On the 18th of July, 2025, Dr. Nihar Desai from Princess Margaret will be speaking to us on a very interesting topic, which has garnered a lot of enthusiasm in recent ASCO and EHA, where he'll be speaking to us regarding post-transplant cyclophosphamide in the Indian setting. How can we effectively use to reduce our transplant costs while maintaining excellent rates of GVHD prevention? This is our team at Fortis Institute of Blood Disorders, where we are a group of 10 doctors, 5 hemato-oncologists, 5 from the adult side, 5 pediatric side, along with, request everyone to mute. Dr. Harish, if you could mute yourself. I request everyone who has joined in to kindly mute themselves. This is our team from Fortis Institute of Blood Disorders, where we are a group of 10 hemato-oncologists, along with infection disease specialist, extensive hematopathology team, ID physician, nutritionist, clinical pharmacist. Thanks to this excellent team, we are able to perform a large number of transplants and cellular therapies while dealing with both benign and malignant hematology cases. I'll stop here and I'll hand over the session to Professor Khurana.
Great. Thank you, Nikhil, for the very kind introduction. Give me a second here. I want to share my slides. You can see them, right?
Yeah, your slides are visible.
Okay, perfect. So thank you for the introduction to both Dr. Bhargava and Dr. Kumar. I will talk a lot about therapeutic anticoagulation, mostly in the context of cancer-associated thrombosis, but I think you'll get a lot of sort of ideas of what's happening broadly in the anticoagulation world from this topic. First of all, to sort of describe why thromboembolism is consequential for people with cancer. So venous thromboembolism is common in people with cancer. It occurs in about 1 out of 5 cancer patients at some point during the natural history of the illness. And when it occurs, it is associated with a lot of bad consequences. There's a need for prolonged therapeutic anticoagulation, so you have to go on a blood thinner sometimes for the rest of your life. And paradoxically, that it's also associated with an increased risk of bleeding. Once you get one blood clot, you're at risk for a second blood clot. So there's an increased risk of recurrent VTE. There's increasing costs associated with this, including VTE costs, healthcare costs, can delay or interrupt anti-cancer therapy, affect quality of life. And there's a lot of data, and I'll show you some of the data that actually the occurrence of VTE in people with cancer increases short-term mortality and worsens overall survival. So lots of bad consequences associated with thromboembolism in this setting. Although cancer-associated thrombosis has been known for over a century and a half, the incidence is actually not going away, but is increasing over time. On the left are data from a very large Danish national registry looking at rates of VTE in the cancer population and in the non-cancer population for a 20-year time span from 1997 to 2017. And you can see that rates of VTE in cancer patients have gone up over time. This may be related to increased survival of cancer patients. If you live longer, you have more of a chance of getting blood clots. It may also be linked to an increased thrombogenicity of newer cancer drugs, such as targeted agents and immune checkpoint inhibitors. In contrast, as you can see from the red bars, the rates of VTE have not really increased in the non-cancer population. So this is really affecting the cancer population more than the non-cancer population. You see similar results in a time span of 2005 to 2017 in the California Cancer Registry on the right. The 3 colored bars, they represent 3 different eras. The most recent era is 2014 to 17. And as you can see, across different types of cancers, the rates are higher in the most recent era compared to the baseline era. And it doesn't matter whether you're looking at kidney cancer, lung cancer, prostate cancer, every cancer, there's an increased risk of thromboembolism over, in this case, a 10-year time span. Mortality related to cancer-associated thrombosis has also gone up. These are data from a large death certificate registry in the United States by SAD and colleagues that was just published this year. And you can see overall trends related to cancer-associated VTE have gone up in this time frame, with a particular spike in the last 3 or 4 years of this data. Why does cancer-associated thrombosis occur? There's a lot of different reasons why it is happening, and we actually don't have a full understanding of exactly why it's happening. But there are several different mechanisms that have been explored and identified. There's definitely increased platelet activation, which can lead to increased thrombus around isolated tumor cells, as well as in the context of vessel systems. There's also leukocytosis, which is associated with neutrophil extracellular traps, or NETs, which can contribute to thrombosis. Tumor cells release tissue factor-bearing extracellular vesicles, and these EVs can go into the circulation and carry tissue factor to different aspects of the blood circulation and cause clots. The contact pathway is also activated, with circulating levels of activators of factor 12 are increased in many patients with cancer. And then plasminogen activator inhibitor is also increased. And there's some data that protoplanin is overexpressed in brain tumors and other cancers and can induce platelet activation as well. Most recently is the paper from the right that was just published in Cell a couple months ago, further delineating the importance of small extracellular vesicles, which are released by the tumor, both primary and metastatic tumors, and find like a lung prothrombotic niche and interact with beta integrins and lead to both progression of metastases and thrombosis. So dual effects on cancer progression and thrombosis progression. The rates are also associated with inflammation, and this is very starkly shown by the rates of VTE with immune checkpoint inhibitor therapy. Our group was the first to report this back in 2021, where you can see in a large retrospective cohort study of close to 1,700 patients receiving immune checkpoint inhibitor therapy, we found that almost a quarter of patients had some form of VTE. This included DVT-PE and visceral vein thrombosis. And even if you exclude visceral vein thrombosis, then VTE still occurred in about 20% of patients. And more importantly, the VTE was associated with decreased overall survival. So if you take the same patient, same type of cancer, same immunotherapy, and if they have a blood clot, if they don't have a blood clot, survival is worse if you have a blood clot, adjusting for everything else. In this study, the median survival was about a year with VTE versus 450 days. So, slightly a year and 3/4 with, or a quarter without VTE. Similar results were shown by a large study from Vienna, looking at 600 patients with cancer treated with immune checkpoint inhibitors, follow for about 8 months. And as you can see in their analysis, this was shorter time frame than us, so less VTE, but still very high rates of about 13%. Arterial thromboembolism was about 2%. Again, impact on survival. Median survival after VTE was 12 months versus 25 months without VTE. So almost a doubling of, or cutting survival in half if you had VTE with immune checkpoint inhibitors versus without. The treatment is even more complicated when you look at immunotherapy with chemotherapy combination. So these are data from lung cancer patients that we published a couple of years ago in JITC, looking at the VTE incidence rate with immunotherapy, with chemotherapy, and then immuno plus chemotherapy. And as you can see in the picture here, this is the total rate, this is the 6-month rate, and this is the 12-month rate. And in every situation, the immune chemo combination has the highest rates of VTE, which you would kind of expect because it's more drugs, both of which cause, both classes of drugs of which cause VTE. So again, the problem's not going away. If anything, it's getting worse with the advent of immune checkpoint inhibitor therapy. Although my talk today is going to focus primarily on venous events, it's also important to know that arterial events also increasingly associated with cancer. These are rates of arterial thrombosis both before and after. The picture on the left is the rates of arterial thromboembolism. So this is mostly MI and stroke, and then a few cases of peripheral arterial embolism. And as you can see, the rates are in the normal range compared to control patients. And then about a year before they start to increase, and then right around the time of cancer diagnosis, they peak. Similarly, they continue to rise after cancer diagnosis and rise for several months, maybe even up to a couple of years after diagnosis of cancer. Whether this is an effect of the cancer or whether it's an effect of the cancer plus the Cancer treatment, we don't really know, but this is now well documented in these large clinical trials. So both venous and arterial thromboembolism are increased in people with cancer. So for my talk today, I want to focus on sort of 4 different aspects of this field. One, as you heard from Nikhil already, is risk assessment. So even though many cancer patients develop blood clots, not all of them do. And how do you identify the ones who are more at risk for getting blood clots versus those who are not? Second, how can we prevent blood clots from happening in the first place? Third, how can we treat blood clots if they already occur? And then finally, factor 11 inhibitors are just starting out, and there's a lot of ongoing trials, both in the cancer and non-cancer setting. And so I want to just introduce you to this new class of therapeutic anticoagulants that hopefully will arrive to market in the next couple of years. So let's start with the first, which is risk assessment. So very easy way to do risk assessment is just to look at the type of cancer. And historically, we've known this. This has been shown by multiple different studies. I'm just showing you sort of one of the more recent studies as an example. Rates of thrombosis vary very substantially by the type of cancer. And there are some cancers that are very well known to be associated with risk of thrombosis that include pancreatic cancer, primary brain tumors, bile duct cancers, and cholangiocarcinoma, some types of non-Hodgkin's lymphoma, particularly the diffuse large B cell. Gastric esophageal cancers, myelomas, especially in association with IMiD therapy. And then some cancers actually have very low rates of VTE. So melanoma, prostate cancer, thyroid cancer, CLL, CML don't have very high rates, MDS. So big difference just by the site of cancer. And that's certainly one way we can distinguish cancer patients from non-cancer, or high-risk cancer patients for VTE versus non-cancer patients. But type of cancer is not the only risk factor. Shown here is sort of a list of all the different risk factors for cancer-associated VTE. They do include the type of cancer, but they also include other features of cancer, such as the histology. So more likely with adenocarcinoma than squamous cell cancer. Grade, more associated with poorly differentiated than well-differentiated. The initial period after diagnosis, so the first few months after diagnosis of cancer, is the highest rate for development of VTE. Treatment-related risk factors, including surgery, hospitalization, systemic therapy, the chemotherapy, immunotherapy, anti-angiogenic therapies like bevacizumab with arterial events, sunitinib, sorafenib with arterial events, cabozantinib with venous events. Patient-related risk factors, so older people more likely to get blood clots in the US. African-American patients are more likely to get blood clots. Comorbidities, so the more kidney disease, pulmonary disease, heart disease, the more likely to get blood clots. And then a bunch of biomarkers, including simple biomarkers like white cell count, hemoglobin, platelet count, and then more complex biomarkers such as tissue factor, D-dimer, P-selectin, and more recently, genomic biomarkers, including specific somatic mutations and ctDNA. So to make sense of sort of all of these different bewildering array of risk factors, about 15 years ago, 20 years ago almost, my group and I put together what was the first risk assessment tool for identification of people at high risk for DVT or PE. And it takes into account sort of the 5 most common contributors to cancer-associated thrombosis. So the type of cancers, if you have stomach or pancreatic cancer, you get a score of 2. If you have other high-risk cancers, such as DLBCL, lung cancer, kidney cancer, you get a score of 1. High platelet, low hemoglobin, high white cell count, and a high BMI all get a score of 1. In our initial classification, we categorized patients into 3 different categories: low, intermediate, and high. Low was a score of 0, where the risk of VTE was less than 1%. Intermediate was a score of 1 or 2, where the risk of VTE was around 2%. And then high was a score of 3 or higher, where the risk of VTE was around 7% over a 2.5-month period. Since then, other people have validated our data, and newer classification now puts it as sort of less than 2 or more than 2. And I'll get into that when we talk about primary prevention. And that basically sort of defines low versus high risk. This paper has now been cited over 2,500 times. There's tons of validation studies of this paper. Last time I checked, it was over 300, close to 400. And it's been validated across 200,000 patients. And the validation of this risk score has taken place in many diverse populations. I'm just showing you sort of 3 examples here. Example on the left is in 27,000 Japanese patients, where they changed the risk score slightly to change the BMI to anything more than 25, because Japanese population, obviously, obesity is far less than the US population. The picture on the right is in a 40,000 patient Danish registry where they checked it both with the original categorization, so low risk, intermediate risk, and high risk, and the newer categorization dividing as 2 or higher versus less than 2, and found similar prediction of risk. And then the bottom is in Costa Rica, where they also found that the risk categorization worked very well. So in Asian patients and European patients and in Hispanic patients, we are able to show the same thing. Since the publication of this score, there have been a bunch of new risk assessment tools. I'm going to show them to you here just to make sure that you understand that they're all out there, and just show briefly how they are different than the original risk score. So Protect takes away the BMI. This was developed in Europe. And so again, BMI is more of a US feature than a European or Asian feature. And so it takes away the BMI as a variable and then adds the type of chemotherapy like gemcitabine or cisplatin. Oncotive, Compass Cat are very specific in certain types of cancers. CAT score is probably the best validated, and it keeps just the site of cancer and then adds D-dimer, and then it takes away all the other variables, but it requires that you check D-dimer on everybody. Target TP adds fibrinogen and D-dimer. Oncotrom adds genetic risk factors, but they're not widely available. And then the electronic health record, EHR CAT, takes the original score and then adds 6 more variables that are found in an electronic health record in the US. Some of these scores have been validated. Some do improve prediction, but it's unclear whether they predict for benefit of prophylaxis. And currently, the only risk score that has been tested in randomized clinical trials to predict benefit of prophylaxis is the original risk score. And so that remains kind of the only recommended one at this present time. I want to point out myeloma because this is actually a very unique population and has its own risk assessment tool. So there's actually 3 risk assessment tools for myeloma, and I want to show them. So myeloma is unique because the risk is driven more by the treatments and other variables than by the disease itself. And so there's a specific score called SAVED, which is for patients treated with IMiD-based therapy, which I know is sort of starting to go out of fashion. And includes points for recent surgery. Asian race actually takes away points. It's -3. Prior history of VTE, age, and then a DEX-based regimen gives you more points. The other one is IMPEDE, which is not just for IMiD patients. So it includes IMiD therapy is given points, but also includes BMI, recent fracture, ESAs, DEX-based therapy, doxorubicin-based therapy. Again, takes away points if in the US you're an Asian patient, adds points for history of VTE, and then has other points assigned to it. And then finally, our group led by Raj Chakraborty, who is currently in New York, developed this PRISM score, which actually takes into account abnormal metaphase cytogenetics. And so it has very simple 5 variables. Prior history of VTE, you get 8 points. In the US, African American race gives you 1 point. IMiD use gives you 2 points. Recent surgery gives you 5 points. And then abnormal cytogenetics gives you 2 points. And as you can see, very nice separation of the curves for high risk versus low risk. So myeloma, unique population, a little bit driven by IMiD use, race, and then abnormal cytogenetics. There are also new biomarkers that are being tested. These are data specifically from immune checkpoint inhibitor therapy. This is again from the Vienna group that took about 800 patients, 2 different cohorts, being treated with immune checkpoint inhibitor therapy and then followed for VTE. And what they looked at was the rate of CRP rise. So CRP is C-reactive protein. They didn't go by the baseline. They just checked it at baseline. And then they looked to see what happened to people if the CRP went up, if it stayed stable, or if it went down. And if you look at what happened, it's pretty clear in this table over here. If the CRP goes up, your incidence of ET is very high. It's around 11%. If the CRP stays stable, it's in the middle. It's around 6 or 7%. And if the CRP goes down, then it's around 3.5%, 4%. So it looks like if ICI inhibitor therapy causes enough inflammation to cause the CRP to go up, you're more likely to get blood clots. So very interesting data with dynamic biomarker modeling as opposed to a baseline biomarker model. So very interesting data, and hopefully this will help us give some clues on ICI inhibitor therapy. Another biomarker is ctDNA, or circulating tumor DNA. This is published from the Sloan Kettering group just last year. Basically, more ctDNA, higher risk of VTE, less ctDNA, less risk of VTE, tested again against the existing score, and both the score and ctDNA were both significant in this analysis. It looks like they contribute to the risk of VTE, but separately. It's not a big surprise because ctDNA essentially is reflecting whether you have cancer or not. Obviously, if your cancer is in remission, or if it's so suppressed that there's no measurable ctDNA, then your disease is not as bad as somebody else. So not a big surprise, but it kind of brings us into the era of ctDNA. So more to sort of learn from here as we move forward. So that's what's new on risk assessment for VTE in the cancer population. I will now move on to primary prevention, where there has been a lot of activity in this space as well. So for about a decade and a half, there were a lot of clinical trials that looked at primary prevention of VTE. So primary prevention is taking people with cancer, giving them a blood thinner, and trying to prevent them from getting blood clots. And the initial trials all suffered because they took an approach that was not risk adapted. So they just took a bunch of cancer patients and gave everybody blood thinners. And as you can see here, two of these large randomized trials, one was in Lancet Oncology, one was in New England, very high impact publications. But if you look at the rates were actually very low. In PROTECT, using nadroperin, which is a low molecular heparin for primary prevention, 4% down to 2%. In SAVE-ONCO, 3.5% down to 1.2%. So big relative risk reduction, but absolute risk reduction is only 1 to 2%. So number needed to treat to prevent one VT is in the 50s, which almost no primary prevention strategy would use a NNT of 50 to recommend prophylaxis. So the trials were successful, they met the primary endpoint, but the clinical significance was not great, and so they kind of died. What I want to show you is what we did if we apply the risk factor to the same trial. So this is published by the PROTECT people, and again, the total rate was 4% down to 2%, but they included a bunch of people that had low risk for VTE. And in that population, it was 3% down to 1.7%, but they also had a bunch of people with high risk for VTE, as you can see on the right. And there, the absolute improvement was much greater, 11% down to 4%. Number needed to treat dropped significantly down to 15. And this has been shown in multiple other analyses of high-risk populations as well. If you take just the high-risk population, apply the risk score, only treat high-risk patients, you'll get a much greater benefit, absolute benefit for patients, and the number needed to treat will drop quite significantly. My group and I also completed a large randomized clinical trial. There's a large randomized trial from Canada that was also completed. Both our studies are published in the New England. And if you take together all of these different primary thromboprophylaxis trials, put them in a meta-analysis, you can see here for a score of 2 or higher, relative risk is quite substantial. 3 or higher, it's even greater. And if you go by number needed to treat, shown here in the white portion of this graph, 2 or higher, it's around 20, 3 or higher, it's around 15. Number needed to harm, so there's actually no real harm because basically it approaches infinity. And then mortality, none of these trials were looking at mortality, but you can see the bars are all towards the left, which actually shows the absolute risk reduction favoring primary prevention. So based on all of these multiple randomized trials, current guidelines recommend primary prevention in high-risk patients. These are the ASCO, NCCN, ITAC, ISTH, ASH guidelines, essentially all the same, saying, hey, do risk assessment using the Krana score of 2 or higher, offer prophylaxis if there's no concern for bleeding. And prophylaxis can be either a direct oral anticoagulant like apixaban or rivaroxaban, or it can be low molecular weight heparin. Just because heparin is so hard to give daily self-injections, most people would opt for the oral agents. For low risk for VTE, so Krana score of less than 2, no routine VTE prophylaxis is recommended. And essentially, this is replicated across all of the different guidelines. What's more important is how do we take these large randomized clinical trials data, all of these guidelines that are recommending primary prevention, and apply it in the clinic. And the best data actually just came out in the last week. So this is very new data from ISTH that just concluded 2 days ago. This is done at the University of Vermont. And so it's called the Vermont model. And what they do is they take cancer patients who are starting new treatment and educate them about VTE and automatically calculate their risk. And the risk is calculated either based on the Krana score or PROTECT. And they also assess for bleeding risk. Only the high-risk patients are approached, and they're approached by either a pharmacist or by an APP, which is like a nurse practitioner or a physician assistant. So they have a specific service that just goes to cancer patients while they're getting chemo and says, hey, our computer calculated that you are at high risk for getting a blood clot. Here's what you can do to prevent that blood clot. Do you want to go on a blood thinner? In the initial paper that was published a few years ago, they showed that about 23% of the population was identified as high risk, 70% were offered referral to the service, and of those 71%, 94% received VTE prophylaxis, showing that patients will accept outpatient VTE prophylaxis if they're shown to be high risk. The update this week was looking at the outcomes in these patients. So now they followed them for a couple of years, and you can see whether you look at VTE at 6 months, PE at 6 months, or DVT at 6 months, substantial reduction if you are given prophylactic anticoagulation. So this is not a randomized trial. It's actually a trial. It's a study of implementing guidelines in the outpatient clinic, and rates are down from close to 8% down to 3% for all VTE. PE rates cut in half, DVT rates cut in half. Really impressive trial. Even more important is that thromboprophylaxis was associated with reduced mortality, 31% down to 17% with prophylactic anticoagulation, p-value highly statistically significant. So this again confirms the benefit in the real world setting of outpatient prophylaxis for cancer patients, not for everybody, but for people who are at high risk for VTE. Hopefully the paper will come out soon that we can study this, but brand new data, just a couple days old. All right, moving on to treatment. So two sections on treatment, and then I'll stop. So first is, of course, sort of a description of what's happening with treatment, and the second is what's coming or going to happen with treatment. What's happening with treatment is, obviously a long evolution over time. So it's been over 100 years since heparin was discovered. It's been about 75 years since vitamin K antagonist, warfarin, was introduced into clinical practice. It's been about 60, 70 years since heparins became sort of standard of care for VTE treatment and then for VTE prevention in the post-surgical setting. And now it's been about 20 years since the development of direct oral anticoagulants, and sales of DOACs now in the US are in the $30 billion plus range worldwide, actually. And a lot has changed in terms of treatment of cancer-associated VTE, thanks to a huge series of randomized clinical trials. They're all listed here. So Hokusai VTE, which compared edoxaban with low molecular heparin, SELECT-D, which compared rivaroxaban with low molecular heparin, Adam and Caravaggio, which looked at apixaban versus low molecular heparin, and Castadiva, rivaroxaban, and then Canvas, which was what's called a pragmatic trial. So any DOAC versus any low molecular heparin. All of them showing the same thing, that DOACs are basically as good as or slightly better than low molecular heparin in preventing recurrent DVT. So no question, every study essentially showed the same thing. And so based on efficacy, no question, DOACs are better. They reduce risk of recurrent DVT, PE, and are easier to take. It's daily or twice daily pill compared to daily self-injection or twice daily self-injection. But there are some concerns for DOACs in the cancer population in some studies, not all studies. Hokusai VT and SELECT-D, which used edoxaban, both showed that in the GI cancer population, there was an increased risk of bleeding, but not in the non-GI population. In Caravaggio, which used apixaban, they didn't see high rate of bleeding at all. Now, whether this was because Caravaggio took place after the first two trials, and so were doctors just better at screening for which patients to enroll on the trial, or is apixaban really better? We don't know because there's no head-to-head study in the cancer setting, but certainly based on the conglomeration of data, there's concern about bleeding risk in the cancer population. So this is the algorithm that I typically follow. If you are concerned about a bleeding risk, so it's a GI cancer with an intact primary. So a rectal primary, an esophageal primary, gastric primary that has not been resected, or there's other concern for bleeding, or if there's drug-drug interactions, then I use a low molecular heparin. Everybody else, I use a DOAC, which means that 70-80% of my patients will go on a DOAC. And that is kind of the national standard in the US also. Brand new data, this is from the New England from like 4 weeks ago or 6 weeks ago, is extended treatment. So we know that DOACs are very effective in the first 6 months after acute VTE. But what do you do after 6 months of VTE treatment? Because many patients at the end of 6 months still have active cancer, or they have chemotherapy and they're going to stay on it. So these are the results of the large randomized trial known as EPICAT.
Recording in
2.8%, so
progress.
numerically lower met p-value for non-inferiority, and then bleeding definitely lower, 12% versus 16% almost, and met the p-value for superiority. And the mortality was also slightly lower, not significant, in reduced dose versus full dose. So this is a practice-changing trial. Extended anticoagulation is non-inferior to full dose apixaban, has less bleeding, and so basically has become the new standard as of a couple of months ago. So again, brand new data in terms of treatment of VTE, not in the initial period, but in the extended period following anticoagulation, so post 6 months of treatment. All right. So that goes on to treatment. Finally, new class of drugs emerging is factor 11 inhibitors. This comes from a very interesting conceptual approach, which says, hey, hemostasis and thrombosis are actually two different things. And hemostasis is driven by sort of this pathway shown on the left, which is tissue factor leading to 7-10 activation, eventually leading to fibrin formation. And a lot of the drugs that we have target the hemostatic pathway, but that also leads to bleeding. What if we targeted this other pathway, which leads to pathological thrombosis, which is the factor 11 pathways, 11, 9, 8, 10, 5, leading to fibrin formation, and that would not impact hemostasis and therefore would not impact bleeding as much. That was the theory. So uncoupling hemostasis from thrombosis. So hemostasis is the target of DOACs and warfarin. Thrombosis would be the target of either a factor 12 or a factor 11 inhibitor shown on the right, where you would affect thrombosis formation, but not bleeding. And there's also a lot of evidence supporting factor 11 as a target. This genetic epidemiology studies that showed that people with high factor 11 levels have greater risk of thrombosis, but low factor 11 patients have reduced risk of thrombosis. There's also people with congenital factor 11 deficiency, and those people have no spontaneous bleeding. So it's not like hemophilia or not even like von Willebrand's. And there were animal studies that showed that factor 11 inhibition inhibits thrombosis in many different animal models without increasing bleeding. So this whole class of drugs has developed around factor 11 inhibitors with many different mechanisms of action. So there's antisense oligonucleotides, there's monoclonal antibodies, and there's small molecule inhibitors. And they all work in different mechanisms, as you can see here. Some are parenteral, some are oral, some have rapid onset, some have slow onset. So many different things to learn about this, this large class of drugs. But we now have clinical data. First up is this New England paper that looked at patients with atrial fibrillation getting either a factor 11 inhibitor known as abelacimab, which is a monoclonal antibody, that is given once a month. So it's not a pill that you have to take every day like rivaroxaban or twice a day like apixaban. It's a once a month injection. In this study, I think it was IV, but there's ways to also give it sub-Q. And if you look at rates of bleeding, huge difference for 150 milligrams or 90 milligrams of abelacimab versus rivaroxaban, much less bleeding with the factor 11 drug as compared to rivaroxaban, so a direct oral anticoagulant. Based on sort of all of these data, there are now actually 2 ongoing randomized trials of treatment of acute VTE, specifically in people with cancer using abelacimab. Aster, which is comparing to apixaban, and Magnolia, which is comparing to dalteparin. And they're looking at primary efficacy of recurrent VTE, and then the principal safety outcome is major bleeding plus clinically relevant non-major bleeding. And we'll have to see what those results show. Trials are currently in active enrollment for both of these studies. This drug was actually originally came from Novartis, then was spun off into a small company called Anthos. And now Anthos was rebought by Novartis, so it's again a Novartis compound as of this month, I think. Second set of drugs comes from Regeneron, which has 2 factor 11 antibodies that they're currently testing in small phase 2 trials in the cancer setting. And the hope is that they'll test in larger phase 3 trials in the cancer setting as well. So more to come more to come there also. So to summarize, cancer-associated thrombosis is an important clinical problem, high prevalence, high incidence, including with new cancer drugs such as immune checkpoint inhibitors, associated with worsened survival, associated with a high risk of recurrent VTE, and paradoxically also bleeding. We've made a lot of progress. I described to you improving risk assessment approaches, new biomarkers, clear benefit of risk-adapted prophylaxis, growing therapeutic options. We have, heparins, warfarin, direct oral anticoagulants, and now coming soon, factor 11 drugs, and now evidence for extended duration dosing. Lots of knowledge gaps remain. We don't fully understand the bleeding risk in the cancer population, so that's important to understand better. Implementation science for risk assessment and prophylaxis. We've had the prophylaxis randomized trials now for several years, but they have not been implemented in the clinic, and so we need to do that. And then to better understand the role of factor 11 inhibitors, for which there are ongoing clinical trials. So I will stop here and happy to take questions. Thank you.
Thank you, Dr. Kurana. That was an excellent talk. You comprehensively covered the topic cancer-associated venous thromboembolism, including all the new updates and the new drugs. Looks quite promising in early clinical trials. A lot of questions which has poured in from all over the country. So we'll start off with that. And in case whoever has joined in here and the organizers, any questions, please feel to drop in the chat box. So whenever we treat patients with DVT or a new onset thrombosis, there is a lot of debate regarding what actually constitutes a provoked thrombosis. So one of the questions which has come in, 45-year-old male, no prior comorbidities, developed a right lower limb proximal DVT after 6 to 7 hours of air travel. So does this constitute a provoked thrombosis, and what would be your strategy for such patients?
Yeah, generally speaking, I think air travel is considered a provoked thrombosis because there was a provoking factor. Now, millions of people travel in economy class every day and don't get thrombosis. So, you do sort of wonder about why is somebody getting it and not getting it. There's in general, you want to treat these patients, and then there's a question of, how many of these patients need to be investigated further for other etiology. But I think that's sort of a case by case basis. So you have to understand, did they have surgery 2 weeks ago before they got on the plane? Are they on birth control pills? Are they on hormone replacement therapy? Do they have cancer? All of those questions. I think it's an individual case by case basis, but I would consider air travel to be a provoking factor.
And in such patients, do you start a DOAC upfront with a loading followed by a maintenance dose?
Yeah.
And what would the duration of anticoagulation be? Would you give them for 3 months? Would you continue for 6 months? Do you
Yeah,
repeat
it
it?
depends on the type of clot. So, is it an isolated distal clot? Is it a proximal clot? Is it a PE? As you know, there are sort of scores designed to sort of look for risk of recurrent VTE. In men, the risk is higher than in women. And so it kind of, again, comes down to individual risk factors. But I would say minimum 3 months. And in many patients, I would even do 6 months. So.
Post-pregnancy patient develops a distal DVT. How long would you continue anticoagulation? Again, something which we would consider probably as a provoked thrombosis.
Yeah, that would be a provoked thrombosis. Post-pregnancy would be, if it's an isolated distal DVT, I think 3 months would be sufficient.
And 3 months versus 6 months or extended anticoagulation, does D-dimer or a repeat screening ultrasound help us in making this decision? Do you repeat a Doppler before you say, okay, now we'll stop?
Yeah, we typically don't. These repeat ultrasound studies are very operator dependent, and there is not a lot of concordance between different operators. In terms of, is it residual thrombus or is it just, scarring in the vein or something like that? And so we don't typically rely on repeat Dopplers. There are some centers, especially in Spain, I think they have this history of sort of repeating the Doppler. But I think in the US, we typically don't repeat the Doppler. We just make a decision based on individual risk factors about 6 months versus longer. And of course, you have to talk to the patient and gauge their risk assessment, their risk of bleeding, their concern about recurrent VTE. So you have to take all of those factors into account.
If patients have an unprovoked thrombosis for the first time, how extensively do you evaluate these patients for an underlying thrombophilia?
Yeah, it depends on the age of the patient. In terms of looking for cancer, usually, the data has shown that they should have the cancer screening that is age appropriate. So if they're more than 50 and they have not had a colonoscopy, or they've not had a mammogram, or they haven't had a PSA check, then we should do all of those things. But you don't need to do a PET scan. You don't need to do, CT chest or CT abdomen pelvis. So if just do age appropriate screening, but no more than that. The risk of finding a cancer in an unprovoked VTE is typically less than 10%. In many studies, is less than 5%. And extensive screening has not been shown to improve survival. So, if you do usual screening and you find a cancer versus if you do extra screening and you find a cancer, in the end, the cancer is going to manifest itself if there is one. And so so doing extensive testing will not improve survival in that patient. So for that reason, as a public health approach, it's not recommended.
And the same scenario in a younger patient, would you screen them? Would you do a mutations as testing, look for PNH, myeloproliferative disorders, especially many patients, in fact, majority of the patients we see in our clinic with an unprovoked thrombosis, we end up evaluating them extensively and very often we don't find anything. Then the question comes, how often should we screen if there is no clinical indication for PNH, myeloproliferative disorders, factor V Leiden, and a whole lot of other mutations?
Yeah, I think that becomes very challenging. So if it's like a first episode of a proximal DVT, there's been a lot of studies. I didn't, get into that today, but there's been a lot of studies looking at, identifying sort of the risk of recurrence and then the benefit to patients. Um, the I would say the guidelines say don't do genetic testing, but in practice, most people do genetic testing because patients push for it. They're worried about the risk of VTE. Let's say you're on hormone replacement or birth control pills and you want to know, can you continue them or not? Things like that. So I think we end up doing more, but if you go by the board question, then, it's probably you don't need to do it. So.
And when you have to do a thrombophilia workup for these patients, what is your standard approach? Do you have a fixed set of investigations that you do for these patients, or does it vary on a case to case basis?
We have a fixed panel that we just send out, and that they're pretty cheap, so they don't. If you're doing it, you might as well do the whole panel instead of like one thing at a time. So yeah, so we have a panel and we send it out.
And typically in these patients, again, first episode of unprovoked thrombosis, how long do you continue the anticoagulation? Do you stop at 6 months or do you offer them prolonged anticoagulation?
Yeah, I think we do assess the risk of recurrence, and you want to look at cumulative risk over a long period, like 5 years or something like that. And that's really dependent on the details of the index VT event and the risk factors for the index VT event. Are those transient risk factors? Or are they sort of permanent risk factors? What is the patient planning on doing during that time frame? Are they going to be active, not be active? Were they on birth control? Are they going to go back to birth control? Things like that. And then based on that, as you know, there's several risk calculators. So you plug all that information in, and depending on the sort of the risk factors, if the risk is 10% for the first year. For unprovoked VT, it's usually 10% for the first year, then 5% per year after. But then at 5 years, that ends up being quite a lot. And so some patients might choose to be on it. Some patients might choose to not be on it. But at least you have to have a discussion about the 5-year cumulative risk and not like just the 1-year cumulative risk.
So given a choice, if patients are comfortable, you would prefer continuing the anticoagulation at least for
Yeah.
extended periods of time.
Yeah. It
Even
also
if
depends on the patient's experience. If they haven't had any bleeding, if they haven't had like hematuria, if they haven't had like heavy menstrual bleeding, they're more likely to want to stay on it because it's not really bothering them. So it does depend a little bit, because by then they've had, 3 months or 6 months of treatment. So I mean, unprovoked VTE, typically the high risk of recurrent VTE is a little bit higher than the provoked VTE population. So you have to consider that as well. And then there's also the influence of D-dimer. So you can check a D-dimer after going off anticoagulation, and that can help decide as well. So
Dr. Anusha has a question which she has typed out in the chat box. How do you approach a patient who requires therapeutic anticoagulation when the patient is already on a single antiplatelet, or in cases where they have a stent which is put in on a dual antiplatelet? So patient on dual antiplatelets with CAD, stent put in couple of months back, develops a DVT. What would be your approach to anticoagulate this patient?
I mean, the antiplatelet drugs will not prevent a venous thromboembolism, so you definitely want to address venous thromboembolism with some type of therapeutic anticoagulation. So typically, such a patient I would put on a direct oral anticoagulant, keeping in mind that the risk of bleeding is higher when you do a DOAC plus dual antiplatelet therapy. So you do have to keep that in mind. But yeah, this is not something I would just leave to antiplatelet therapy.
Would you give the same dose of DOACs like
Any
apixaban
harm?
twice daily, or would you give a 50% dose?
Initially, I would give the full dose. I think after 6 months, you can consider going down to half the dose.
Yeah, Dr. Anusha, you were saying something. Please go ahead. Are you still there?
No, sorry. I was just asking about dose modification if in case of dual antiplatelet user. You already mentioned it, so yeah.
Moving forward, patient with recurrent unprovoked DVT while on apixaban. So we recently had a patient who was on apixaban for pulmonary embolism, again unprovoked, no obvious risk factors, young male, while on apixaban full dose, and he was compliant to the medications. He developed a recurrent DVT in his right lower limb. So such patients who have a event while on DOACs, what is your approach to anticoagulating them?
Yeah, that's a tough one. So I think the first question you want to ask is compliance. So was the patient really compliant and adherent? Because as you know, even missing a couple of days of the drug can lead to, so the first thing is you want to ascertain compliance and adherence. And I would say 60-70% of the time, such patients, if you sort of push them, they'll admit that they were not really compliant, maybe because of cost, maybe they just got tired of taking the drug. Second, you want to assess any drug-drug interactions. Are they taking something else that is changing, the levels? If you could check factor 10A levels and see, where they are, and make sure that I generally don't, but that is one strategy, is to check factor 10A levels and, try and target them. So that's one option. If they're on a once a day drug like rivaroxaban, then, and they fail, then I would usually switch to a twice a day drug like apixaban. So I think that's another strategy. Or you switch the class of drugs completely. So if they're on a DOAC, go to a warfarin. In the cancer setting, if they're on a DOAC, go to a low molecular weight heparin. So switch the class of drugs and see. And then finally, in the cancer setting, if you get recurrent VTE, you switch from DOAC to low molecular weight heparin. They're still having recurrent events. Then you push the dose of the low molecular weight heparin. So you empirically increase by like 25%. Again, not based on randomized trial evidence, but based on single series that have been published from Canada and from other places. So those are some strategies you can use.
I think that's very helpful. Can you elaborate a little bit on how would you adjust the dosage based on factor 10A levels? If patient is already on apixaban and you check the 10A levels, how would you modify the dose based on that?
Yeah, I would say this is considered controversial because there's no data that says that a certain 10, between people will target typically between 0.8 and 1.2, but there's no data that being in that range is associated with better efficacy. It's an assumption that it's associated with better efficacy, but nobody really knows. But if somebody failed a DOAC and the level is less than 0.8, then they may be having problems with absorption, or it might be an indication of poor compliance or something. So then you're using the wrong class of drugs. Maybe you should switch to warfarin or something else. there's no data to push the dose in DOACs. So in low molecular heparin, there's data that because you calculate based on milligram per kilogram. So you just go with a higher dose. So you empirically increase by 25%. In DOACs, there's no data to push. And frankly, there's no way to push, right? Because, if you're on 5 BID, what are you going to do 5 TID? I mean, that doesn't make a lot of sense. The bleeding risk, I think, would become too high. So the factor 10A level is mostly to make sure it's not low. If it's less than 0.7 or something, then you worry that there's an absorption issue or metabolism issue, and you should try a different class of drugs.
And when you switch these patients to warfarin, would the target INR be still 2 to 3, or would you target a slightly higher INR in these patients?
2.5 to 3.5, yeah. Yeah, if they've had a recurrent VT. So.
In patients on low molecular weight heparin, is there an upper cutoff? Is there a ceiling dose? Let's say someone is 120 kg versus 130 kg. For obesity, do you do dose adjustment for low molecular weight heparin?
It's a good question. So usually you don't, because you're more worried about the recurrent VT. Like the life-threatening event is probably going to be recurrent VT and not bleeding. Most people don't die of bleeding from low molecular weight heparin. So usually you don't do an empiric dose reduction unless the patient is having issues with bleeding. So you're not supposed to empirically dose reduce. You are kind of hamstrung by like the maximum available in a syringe, depending on the availability locally. And so sometimes if you're a little bit over the cap, you might round down to the highest possible syringe, because if you are making patients do two syringes, two pre-filled syringes, they might just skip the second dose, and then you're not going to, get the desired effect anyway. So I do round down to the maximum possible syringe, but not much less than that.
What is your choice of anticoagulations in patient with hepatic and renal dysfunction? CKD patients, liver disease, CLD becomes especially a extremely challenging group of patients, considering they're at higher risk of bleeding. They have deranged coagulation profile. So how do you approach these?
Yeah, very tricky. Renal disease patients is especially tricky because they are at high risk of recurrent VTE and at high risk for bleeding. I think in the US, apixaban recently had a package insert change, so you are allowed to use it for like up to 30 creatinine clearance. And if not, then you could switch to a low molecular heparin or a heparin. But it's just there's no good solution in that population, because you're gonna end up, if you don't anticoagulate properly, you'll have high recurrent VT rates. If you do, you also have high bleeding rates. It's a tough situation, and patients should just be fully informed about that.
Most of our patients, by the sheer fact that it is much more convenient, they have switched to either apixaban or rivaroxaban. But in 2025, what is the absolute indication to use warfarin?
There's almost none. I think you could make a scenario where somebody had like a gastric bypass or had a gastrectomy for gastric cancer, and so you're worried about absorption. Or they had a major bleeding or something like that. So then GI bleeding. So then you would use a low molecular heparin, but then they can't afford it or they don't want to do a self-injection. So then you would use a warfarin. So very small. I can't remember the last time I put somebody on warfarin, to be honest.
In patients with an artificial valve or in APLA patients who
Oh
are
yeah, that's true. Yeah, artificial valve you would consider warfarin. Yeah, I was thinking just the cancer setting, but yeah, in the artificial valve setting, yeah, you would do warfarins.
And a similar question comes up very often in patients with antiphospholipid syndrome, APS, APLA.
Yeah.
And these patients, if they have triple positivity versus double or single positivity, can they still be put on DOACs, or warfarin is still the gold standard for them?
I think I would say warfarin is still the gold standard. I don't really manage APS, so I'm probably not the right person to ask this. You do want to sort of confirm it, but typically warfarin is preferred over DOACs. Some patients you could still use DOACs, but in terms of risk, the preference would be for warfarin.
I think this you already answered. Patient with CAD.
Yeah, I think if it's an APS patient and they had like a viral infection or some type of acute illness or some provoking factor like surgery, then you could consider a DOAC. But for most patients, you're gonna do warfarin.
In patients on oral anticoagulants, especially the DOACs, who require a lumbar puncture, tooth extraction, or a major surgical procedure? Do you always bridge them with low molecular weight heparin? How do you manage them perioperatively?
It depends on the procedure. So there's a very nice study called the Bridge study funded by the NIH, and it was both US and Canada, that showed that sort of thrombotic events are pretty rare in a bridging population. And so you don't always have to bridge. You could just skip like 1 or 2 days, especially for minor procedures. Obviously, if it's like a major abdominal surgery or pelvic surgery, then typically we would switch to low molecular heparin because they may be NPO, or they may be like not fully conscious, and you worry about whether they are taking the pill or not. So I would say for major surgeries we switch to heparin. For minor procedures we just skip the day.
One more question in the chat box. I think Dr. Ramaswamy has a question. What is the time interval between air travel and DVT risk to say that it is provoked? And that's a great question, I think. Is there a definitive answer? Someone has flown, let's say, 72 hours back versus 1 week back. When would you really consider that it is a provoked?
Yeah, I think within a few days, the again, this is very rare situation. I just want to be very clear, and where there is no other risk factor. Okay, so it's just economy class travel, and not they're not also on hormonal therapy, they're not on birth control pills, they're not on they didn't have a surgery recently, they didn't have like heart attack a month ago, things like that. This is a very rare situation, but it's typically within a few days of air travel that we would worry about it. So
Apixaban versus rivaroxaban. Even in the recent ISTH meeting, a lot of debate regarding the COBRA trial. So, do you think with a slightly lower risk of bleeding, apixaban should be the preferred agent over rivaroxaban?
I think that's where the consensus is coming to. I mean, we did not have any head-to-head studies until this COBRA trial. But if you looked at cross-trial comparison, which you're not supposed to do, the bleeding risks have always been slightly lower with apixaban than with rivaroxaban. Whether that's because rivaroxaban is once a day, so you get a high peak, which may be associated with bleeding, whereas with apixaban you don't get such a high peak, and you have more sustained levels over a 24-hour period. Whether that's the cause or whether it's just the drug itself, who knows? But consistently, apixaban studies have had slightly less bleeding rates, and now with the COBRA trial showing almost a 50% reduction at 3 months in terms of bleeding, major bleeding, I think probably I would favor apixaban. But you have to individualize for the patient. Is the patient going to take a twice-a-day drug? Because it could be the best drug in the world, and if they're not reliable and they skip the second dose, then you're not doing the patient a service by giving a twice-a-day drug. So it has to be somebody who's going to take a twice-a-day drug.
Absolutely. And you mentioned very interesting data published in NEGM few months back, where they've tried to switch apixaban to 2.5 milligram twice daily after 6 months. And with the results were similar and the bleeding risk was comparatively lesser. So does this apply to all populations? Like if patients have had atrial fibrillation with a cardiogenic stroke and they were on apixaban 5 milligram twice daily, would you still consider switching them to a lower dose after 6 months?
No, these data are just for acute DVT and PE, either in the cancer setting or non-cancer setting. There's no data in the atrial fibrillation setting that I know of.
Okay. A lot of questions regarding management with respect to post bleeding, but I'll summarize it. Essentially, most questions address at what level of bleeding. If patients have skin bleed, let's say they have a minor gum bleed while brushing, would you stop anticoagulation? And in patients who have had major bleeding episodes like a GI bleed, IC bleed, and such scenarios, when would you be comfortable in restarting them on anticoagulation?
Yeah, very individual. So in terms of the minor bleed, what we call nuisance bleeds, they're not going to end up in the hospital. They're not going to die of it. But it is distressing to patients to see blood in the urine, to see blood when you're brushing your teeth. It's a lot of it is just about education. And, if you can educate patients to ignore it and it doesn't bother their quality of life, then typically we leave patients on it. Usually you say, okay, you can either do this and live with it, or you can switch to a daily self-injection, and most patients would rather live with that than switch to a daily self-injection. I think major bleed is trickier. You almost never want to do immediate anticoagulation after a major bleed because the risk of recurrent bleed is very, very, very high. My practice is to at least wait a month. If it's a DVT, then usually here we would put in a IVC filter, and that protects you for at least a few months. Eventually, you want to go back on anticoagulation. If you have an IVC filter, then sometimes I even wait 3 months before starting. If you can't put an IVC filter because it was only a PE and there's no DVT, then I would start in like a month or so, but no sooner than a month.
And how frequently do you use IVC filters in your practice? In the current scenario that you mentioned, when would you take off the IVC filter? Like after 3 months, once you start them, restart them on anticoagulation and they are tolerating it reasonably well, when would you consider removing the filter?
Yeah, IVC filters are tricky because they're associated with increased risk of recurrent thrombosis because it's slowing the flow down in the IVC. So typically I almost never put in an IVC filter, maybe like once a year or twice a year I might do it. And it's for this very specific reason. Massive DVT, you're worried about PE, or massive DVT already had a PE, but also massive GI bleed, you cannot safely put back on anticoagulation. So you have to do something. So then you put an IVC filter in. But very rarely, like maybe, 1 out of 100 patients.
Dr. Paritosh has a question. For thrombosis prevention, do we consider life expectancy in mind and type of cancer with hemorrhagic tendency before starting the anticoagulation?
Yeah, typically you don't want to consider. Remember, you're starting for prophylaxis, you're using half the dose, you're not using the full dose. So the risk of bleeding is much lower than with therapeutic anticoagulation, but it's still there. So typically you don't want to, in patients with a bleeding risk, obviously you don't want to do it. But most patients are who need prophylaxis are either pancreatic cancer, which does not have a high bleeding risk, bile duct cholangiocarcinoma does not have a high bleeding risk, lung cancer, which, with the exception of hemoptysis, does not have a high bleeding risk. So, unless patient had like a recent GI bleed or major bleed, then I typically am not super worried about the risk of bleeding with primary prevention.
And in these patients, you would start even rivaroxaban or apixaban at half the dose.
Yeah. So it's 2.5 BID of the apixaban or the 10 once a day of the rivaroxaban.
And I think you've already touched upon this, but similar questions, mainly from the neurology setting. Patients with atrial fibrillation, thromboembolic stroke with a secondary bleed. So such patients, because there is an AF, you would ideally want to restart the anticoagulation slightly earlier. Would you still go ahead with apixaban if they have had a bleeding, or would you switch them to low molecular weight heparin when you restart? And if yes, after how long?
Yeah, for atrial fibrillation stroke prevention, there's no data that heparins would help in arterial events. So in that population, it's either your choices of warfarin or DOACs. And then depending on how worried you were about that the DOAC caused the bleeding, then you'd switch to warfarin. If the bleeding would have, if your assessment is that the bleeding would have happened with or without the DOAC, then I think it's safe to go back on the DOAC.
And in patients, especially, we see a lot of myeloproliferative disorders with both arterial as well as venous events. So in such patients, would you give them an antiplatelet with an anticoagulation? What would you approach in these patients who have both an arterial as well as venous thromboembolism?
Yeah, I think depend. Yeah, I think I favor DOACs and warfarins and not low molecular heparins because low molecular heparins have not been proven to reduce arterial events. And then I sometimes do use with an antiplatelet agent, depending on how worried I am about the risk of arterial events. But remember, DOAC plus antiplatelet agent has a pretty high risk of bleeding, so you have to sort of keep that in mind as well.
So these patients, would you be comfortable keeping them only on low molecular weight heparin without adding an additional antiplatelet?
Low molecular heparin, no. For arterial prevention, no. I would add an antiplatelet agent.
And in your practice, how do you manage patients on DOACs who have had a serious bleed? Because the reversal agents very often are not available to us, at least in India. So would you transfuse fresh frozen plasma, cryoprecipitate? If patients have a serious bleed on DOAC, How do you manage them in your practice?
Yeah, almost everybody with a serious bleed on DOACs responds to conservative management of bleed. So, if there's a clear bleeder that's visible, you go down, do an endoscopy, and you ablate it or whatever. Um, or you use FFP or cryo. Our hospital did not approve Indexanet because the cost is ridiculously high. It's like $150,000 for like one dose, and you have to pay that to store it. So, you have to actually buy the drug and it would just sit there for like a year. And so it's like a huge investment just to even have it in the hospital. So we actually are in the same situation as you, which is that we don't have Indexanet available, and we really have had no problems. I don't think you really need it.
A lot of questions related to catheter related thrombosis. And I think in patients with malignancy, especially our set of hematology patients, almost all of them do have a peripherally inserted central catheter or a catheter in situ for prolonged periods of time. So, and it is very, very common for these patients to develop a catheter related thrombotic event. So such patients, is it mandatory to remove the line, or would you consider giving them anticoagulating and maintaining the catheter?
Yeah, these are all great questions. So let's just talk about, first of all, there's different types of catheters. I know in heme malignancies, PICCs are very common,
Yes.
but PICCs also have the highest rates of thrombosis and the highest rates of infection. So in my institution, even with heme malignancies, we actually try and put a port in and not a PICC, because ports have lower rates of thrombosis, lower rates of infection. For ports, we almost never change. So even if you have a clot, you anticoagulate, but you don't take the port out, you just leave it in place. With PICCs, it's a little bit different. You might want to change if you're worried about, I think it depends on, like, I mean, if the platelet count is like less than 10,000 or something, you don't want to do anything at all. So then you leave it in. But if you can safely change it, then probably a PICC I would change and not leave it in. But again, I would encourage you to think about non-PICC approaches for patients even with heme malignancies, because both the risk of infection and risk of thrombosis is very high in that populations.
And if we have to change or remove the catheter, would you wait to anticoagulate for a few days and then do it? Because very often we are worried about whether a thrombus can get dislodged when we immediately pull it out. So should we anticoagulate for a few days, then remove the line, or take it out right away?
You could anticoagulate for a couple of days. I mean, it would be rare to get a PE from an upper extremity DVT, right? So there's not like a life-threatening consequence of doing that. So I think you're probably okay. It depends on how uncomfortable it is and how much symptoms it's causing and how badly you need the PIC to give like chemotherapy or something. So I think it depends on all of this. So I would say it's on a case-by-case basis. I think it's safe. I think if you need to take it out, you just take it out. But most people, you don't have to take it out.
I mean, most people, if it's, once we continue the anticoagulation and if patient is symptomatically better, probably we can continue using the line as well.
Exactly. Yeah.
What is your threshold of platelet counts to withhold anticoagulation? 30,000, 50,000. So this is very pertinent again in our set of patients, where patients are more often than not, they are thrombocytopenic. So when would you decide to?
Yeah, we wrote a guideline on this topic. There's no data. That's the problem. There's no evidence whatsoever. I think by consensus, most experts would say that over 50,000, you're fine using full dose. Between 30 and 50,000, I'm a solid tumor doc. For me, that would make me nervous. I think for heme malignancy doctors, probably 30 to 50,000 is also okay with full dose. But the way we wrote the guideline, I think we said half dose anticoagulation between 30 and 50,000. And then below 30,000, you definitely have to stop anticoagulation. If you're very, very worried about thrombosis, then you can transfuse platelets, keep it above 30,000, and then use anticoagulation. But obviously, that's very expensive way to do it. So.
And would your approach differ in patients with heparin-induced thrombocytopenia, DIC, and such settings where the prothrombotic risk is high, but typically patients tend to be thrombocytopenic?
Yeah, for sure. Yeah.
So would you keep the target at 30,000 even for patients with
Yeah,
PIC?
you don't change that because the bleeding risk doesn't change even with with HIT. The bleeding risk below 30,000 is still pretty high. So
One of the questions again, young female patient with recurrent thrombosis on apixaban switched to warfarin, had a thrombotic event when the INR was between 2 to 2.5, currently maintained on an INR of 3. So the question is, the routine prothrombotic workup came out to be negative, extensively looked for myeloproliferative disorders, PNH, and a mutation testing. So in your practice, do you do clinical exome or whole exome sequencing or any other additional tests? Because very often we have these patients who have recurrent thrombotic events and we are not able to pinpoint a cause despite extensive workup. So do you do any further testing in these patients?
The type of patient that you're describing, I guess, would be very unusual, and it is somebody that I would consider in. But typically we don't. So it is, I wouldn't say it's routine to do it. I think you can make an exception in very unusual cases to consider it. I think the yield of finding something on whole exome sequencing is very, very low that you haven't already found with all the screening tests that you've done. So I would say typically we don't do it.
Next one is a case scenario. 47-year-old female patient, CA ovary, incidentally detected to have prolonged APTT on preoperative workup. Not corrected on mixing study. Further testing revealed lupus anticoagulant. However, patient has no history of thrombosis. Patient is about to undergo surgery followed by chemo radiation. So would you put this patient on a prophylactic anticoagulation, and if yes, for how long?
So it's lupus anticoagulant, and what was the presenting? They had a clot or no?
Yeah. So patient had CA ovary detected to have lupus anticoagulant, and there is no prior history of thrombosis. Patient is completely asymptomatic except for a prolonged APTT detected on routine test.
Yeah. Okay. And the ovarian cancer has been removed, or it's?
The ovarian cancer has been removed. The entire testing was done as part of pre-op evaluation, actually.
Okay. And are they on adjuvant chemotherapy or no?
Yeah, the plan is for adjuvant chemotherapy. So the
I would do prevent prophylaxis during adjuvant therapies for
right.
somebody like this. Yeah. I mean, ovarian cancer gives you 1 point in the score, so you're already a slightly higher risk. And and then throw in this sort of genetic tendency, that would definitely push me over the edge to prophylax.
And you would consider continuing the anticoagulation till the time they are on treatment.
Yeah. Once you're done with chemo, you could probably stop. So.
Right.
It is usually 6 months. So.
I think we have come to the end of all the questions which we have received from our audience. If any of the panelists have any further questions, please feel free to drop them in the chat box. Dr. Paritosh has a question. I think we have already dealt with this. Thrombocytopenic patients with platelet of less than 50,000 with stroke. What would be your strategy? I think what he means is, would you give these patients?
Yeah, I think 30 to 50, I would do half dose anticoagulations.
Great. So I think we have come to the end of all the questions. So Dr. Khurana, last 45 minutes, thank you so much for patiently answering all the questions. The webinar was highly informative, and the question and answer session that followed was wonderful. A lot of real life practical scenarios, day-to-day issues that we face in our routine practice as hematologists, oncologists. You've managed to touch upon all of them. And I'm very sure we would handle patients, we would probably give better anticoagulation for our patients in the days to come. It was a very insightful and valuable webinar. And like you rightly said, lack of data for many of these practices makes it very difficult. But your extensive expertise and real life experience in this field has been great. Thank you once again for answering all the questions and participating in today's webinar. We hope to collaborate with you sometime in the future on similar topics related to anticoagulation and its nuances.
Yeah, thank you so much for the invitation. I enjoyed it. Thank you.
Thank you once again. And I thank all the participants who have joined in from across the world for this webinar, as well as all the panelists who have joined in for the discussion today. Thank you all. For next month's webinar on the 17th of July, we have Dr. Nihar Desai, who would be talking on post-transplant cyclophosphamide and its implications in the Indian setting. I thank each and every one of you who has joined in today for the session. And before we wind up, I also thank MQ Pharmaceuticals for providing this platform to seamlessly conduct this webinar. Thank you all.